So welcome, everyone. Thank you for joining us this afternoon. My name is Twin. I am the program manager at Community Health Resource Center here in San Francisco. A little bit about our nonprofit. We have been around for over 34 years. Our four primary areas of service are nutrition counseling, behavioral health services, health screenings, and of course, health education, which you are here for right now. Without further delay, I will go ahead and stop my share screen and let Dr. Shu-En take it.
Great. Good afternoon, everyone. Can everyone hear me okay? I'm going to assume that's a yes. Alrighty. So thank you for having us. We normally do this in person. So this is our first Zoom version, but it's been about a year since we've all been on Zoom. So I guess we're all familiar with that. So a little bit about us. We are from the University of the Pacific. If you've heard of the University of the Pacific, our undergraduate campus is located in Stockton, but we are a three campus university. And so while the undergrad is in Stockton, we have dental and audiology in downtown San Francisco, which is the picture you see there. And so this is 5th Street here, and this is the 5th and Mission Garage. And that's the Intercontinental Hotel that you see sticking out behind our building right here. And so that's where we're located. We are a Doctor of Audiology training program. And so we do have graduate students with us that are learning in clinic. And so today we're here to talk about a deeper understanding of the ear, not the hear, which is a typo bingo. And our clinic campus, we have 4 academic professors, 2 clinical professors, and several adjunct clinical instructors that work with our students. So we have faculty clinic, and we also have faculty-led student clinic, meaning that there are days where we have students with us, so our appointments are longer, so that our students are able to train and learn with their hands-on, with the faculty member present at all times. We're also the first Doctor of Audiology program in Northern California, and there's actually a few more programs opening up this year. So we'll be joined by some of the Cal State institutions in the fall. So it's an exciting time for audiology in California. So a bit about us. I'm the clinic director of the San Francisco clinic. We also have a clinic on our Stockton campus location, which has actually been there for over 15 years. So we are the younger sister campus clinic in downtown San Francisco, and we've been open since 2015. So we're in our 6th year of operation. Dr. Henderson Sabes is one of our tenure track professors, and she teaches a lot of didactic courses. She also pops up to the clinic occasionally, and she also has an appointment with UCSF doing some research with them as well, and I'll let her talk about that. Maybe now, maybe later. I'll let you go now.
Sure, I can pop in right now. I'm Jennifer Henderson Sabes. As Dr. Lin mentioned, I spent about 20 years at UCSF before I came to UOP, so I have maintained that relationship. And I do have a special interest in tinnitus, which we'll talk about today, in the rehabilitation of the auditory system, which we'll also talk about today, and also effects that can change the ear and the brain function after either hearing loss or toxic medication. So that's where I come from, and those are my interests. Thanks so much.
Alrighty. All right, so let's jump into our program. So we have an action-packed hour for you ahead. To start, I'll go over the mechanics of hearing. We're going to delve a little deeper into understanding what hearing loss is, how it happens, and why it's so individual. I think there's a lot of misconception around hearing loss, or we'll get into that shortly. And then part 2, Dr. Henderson Sabes will talk about the brain and hearing loss and tinnitus, as well as sound therapy. And then we'll end with consequences of untreated hearing loss, as well as current technology available to treat hearing loss. Alrighty, so here we have a nice picture of our ear. And so to give you a little understanding about what hearing loss is, you know, a lot of people don't think about hearing loss. It's one of those things that you don't think about until it's gone, and then you're like, what happened to it? So let's talk about sound waves. So sound is a wave that travels through the air. And so if you think about what sound is, it starts as a vibration. So let's say as I'm speaking right now, there are vibrations coming out of my mouth, and it travels through the air. So over here you see the air waves traveling. Can you see my cursor? Yeah, okay. So we have the sound waves traveling into the ear, and that's sound pressure. So when sound pressure hits your eardrum, if my hand is your eardrum, it starts to vibrate. So it's a mechanical energy. So it's vibration that turns into mechanical energy at the eardrum. That eardrum vibrates, which is attached to these three little bones in your middle ear called the ossicles. And so, you know, they're commonly known as the tiniest bones in your body. And so the vibrating eardrum connects to these chain of bones, which is also mechanical energy. And the bones connect to an oval window in the inner ear of hearing. So the inner ear is embedded in your skull bone. So it's a bony shell, and it's filled with fluid and lined with a membrane. And so what happens is you have air pressure that becomes mechanical energy in the middle ear. And then as it connects to the inner ear, it becomes a fluid wave. So it becomes like a wave, like in the ocean. And that traveling wave will travel through the cochlea. And if we take a little close-up of the cochlea, so this is the cochlea right here, that's that bony shell embedded in your skull. This is the inner ear. If we unwind that, it looks like this. And it's organized tonotopically, meaning it's organized by pitch. So just like a piano, it's organized with high pitches closest to the outside of the ear and low pitches down at the base of the ear. And so as the sound wave travels down, it will cause a membrane to deflect. And if we take a cross section of this, you see this picture right here. So this is the membrane. So imagine I have like a sheet of plastic on top of a wave. And so when that wave moves, that sheet of plastic moves with it. And attached to that plastic sheet is little hair cells. So when we say hair cells in your ear, there are these little cilia that are attached to that membrane. And so when that membrane moves, the hair cells bend, and then that's what causes the nerve to fire. So that's our little membrane. These are our little hair cells. And then the nerve to the brain is right here. So it goes, that's the little nerve that goes to the brain. So it's a lot of things that happened for your brain to detect sound. So if you just look at how the ear is functioning, there are many places for things to go wrong. And so taking a closer look at those hair cells, if you see this organ here, that's the same picture as this one. And if you peel off this membrane and you take a top-down look at the hair cells, you'll see this. This is an electron microscope picture of the hair cells. So there's 3 rows of outer hair cells and 1 row of inner hair cells, and they look nice and pretty. And so what you see there are an intact cell. So in a normal ear, that's what it looks like. And the cells look nice and neat, and they're all happy and standing in a row. And so what happens is the cells themselves, those hair cells, actually contribute to your tuning of the ear. What I mean by that is think of a concert pianist versus my 3-year-old on a piano. So a concert pianist will have, beautiful finger work. They can play beautiful songs. The keys will move fast. They move distinctly. The sound is really accurate versus think of my toddler's hands just thumping on the piano with 4 fingers at once. She's going to kind of mush different keys all together at the same time. So what happens is when you have all these hair cells that are happy and together, they tune sound very finely. And so when you activate that portion of the ear, it's very fine-tuned specifically for that frequency or pitch. So like you're pressing 1 key on the piano, it sounds really nice. As you start to have damage in the ear, you start to lose these cells. So over time, those cells degenerate and they're no longer there. So this would become very sparse looking. So if we look at normal hair, this is another picture of the hair cells. That's how they look in a normal ear. And as you get more and more damage, you see the bottom picture and they're not happy anymore. There's cells that are missing. They might be missing from one row. They might be missing in gaps altogether. So the degree of hearing loss that you have is correlated with how much hair cell damage you have. The more hair cell damage you have, the less tuning you have, the less hair cells you have. And so what I like to think about is if you've ever been to a really loud restaurant or concert, and when you leave, you feel a little bit deaf, and then you go to sleep and you wake up in the morning, your hearing's fine. So what happens is if you have a sound pressure wave that's loud enough, you can actually blow that membrane off the little cells, they disconnect. And then as you sleep, they reconnect. And then, you know, your ear is okay. That's what we call the temporary threshold shift. So if you're exposed to a loud sound, you feel a little bit deaf for a while. And then when your hair cells reconnect to that membrane, your hearing gets better again. But with repeated abuse, that doesn't happen anymore. You start to lose those hair cells. They don't reconnect anymore. The hair cells disappear. Another analogy I have is if you're walking on a strip of lawn, on your grass, if you walk over a strip of grass once, the grass is fine, it'll just bounce back. But if 50 people keep walking on the same path of grass, eventually that grass will die and you have this little path through your lawn. And so the same thing happens at the level of the hair cell. So what happens is as you lose more and more hair cells, your tuning disappears. So I like this little zebra picture. On top, we have a nice clear zebra. You can see distinctly the white and the black. And that kind of reflects tuning of the ear. So that concert pianist playing a beautiful Beethoven. And then if you look in the bottom picture, at the top, it's much clearer. But as you go down, the picture kind of disintegrates, the white and black kind of meld together. And that's what happens as you lose these hair cells, the tuning gets lost as well. So instead of playing piano with your fingers, it's like you're playing piano with your hands. You're mushing the keys together. So instead of getting one distinct frequency or pitch from the piano, now you're getting a mush of sounds together. So instead of hearing one clear sound, everything starts to come mushy. It's not as clear, or the fidelity is not as good. So a lot of people have different levels of hearing. And so, you can have normal hearing, kind of mild, severe. But what a lot of people forget is when we do a hearing test, it takes a bunch of change at the level of the hair cell before you'd actually start to see your hearing test drop, because the hearing test is not sensitive at the cellular level, right? So you need X amount of damage before you see a change in your actual hearing thresholds. So when you go to an audiologist for a hearing test and they play some beeps, you'll hear beep, 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 and then you raise your hand. And we test that several times, and we test it at different pitches to see how loud sound has to be before you can detect it. So when you have normal hearing, it doesn't mean that you have 100% of all your hair cells. You could be missing some, but we don't know that. You still could have clinically normal hearing. By the time you have mild hearing loss, you definitely have some hair cells missing. But if you take 10 people, all with mild hearing loss, you don't know how different their cells look at the cellular level of the ear, right? Because it's all in a category of mild hearing loss. And so if you, even at the mild range, if you take things down the severity level, so we have mild, moderate, moderately severe, severe, profound, you're going to have a very wide range of hair cell populations from person to person, even though they have the same classification of hearing loss. So one thing a lot of people don't think about is, no hearing loss is equal to another. It's very, very individual, and we can't go in and check your cells because that would involve opening up your ear and your head, and we don't want to do that. So just keep in mind that when you have a hearing test, even if 100 people have very similar scores or outcomes on the actual audiogram, they can have vastly different actual results in terms of outcomes for how they hear, how they perceive sound, how they react in noise. And so it's very personal based on what your ear looks like at the cellular level. All right, so we've talked a bit about hearing and how it happens, what happens at the level of the ear. Now we're going to delve into, how do you know you have hearing loss? So when do you know your hearing is going? For a lot of people, you don't really notice until someone says something. Usually family members, spouses, children, grandchildren, or people start complaining, like, I'm really having to yell at you. And then you might say, well, actually no, you're just mumbling, or you're turning the TV too loud, etc., etc. Usually the first place people notice difficulty with their hearing is in more challenging situations. So you might notice that when you're at home, you don't have any problems, but when you go out or you're in a group situation, you notice that much more. Obviously, this has been a complaint we haven't had as much of in the last year, since no one can go out anyway and no restaurants are open. But as things come back to normal, most people find that it's situations like this, group situations, meeting rooms, conference calls, people that are sitting farther away from you, or people with softer, high-pitched voices, children's voices, grandchildren's voices. That's where people first report difficulty. Another common one is TV. Like your family members complain your TV is too loud, and it's loud, but you need it at that level to really get the dialogue. So looking at just the demographics of who hearing loss affects, according to the WHO, about 328 million adults have hearing loss, and of those, 5% are children, 23% are young, 18 to 44, 29% are 45 to 64, and 43% are over the age of 65. So it is common, but it's not normal. So a lot of people conflate the two. They say, well, my hearing's normal for my age. Yeah, it means it's common for your age, maybe, but you can be 90 and have normal hearing. So it's not that it's abnormal to have hearing loss, but just because it's common for your age group doesn't mean you shouldn't do anything about it. So, we've discussed the common complaints: mumbling, having to have people repeat themselves, TV is too loud, or, it's okay, and then suddenly there's like music in the background of the TV, and then you don't know what they're saying anymore. Tinnitus, which we'll discuss as a whole section on its own. Ringing in the ears. Telephone conversations become increasingly difficult, especially accents. People find that accents become much harder, which is true. It's much harder to understand accents, especially when you have a hearing loss. Or one common thing is when you're in the car. If you're sitting in the back seat, or someone's sitting in the back seat speaking to you and you can't hear what they're saying, they're talking, you hear the voice, but the speech is indistinct. You've been told that you speak too loudly. Everyday sounds you don't really notice, or they're really soft to you. So, the faucet might still be dripping, or your turn signal has been on for a while, but you didn't hear that ticking sound. Doorbells become softer. Phone calls, sometimes you're missing. With phone calls and doorbells, it takes much more of a hearing loss before you don't hear those. But again, it's frequency dependent, right? So just because you can hear some soft sounds doesn't mean you can hear all soft sounds. And because of the way the ear is built, when the high pitches are closest to the outside, the high pitches tend to go first. And so, you don't hear birds chirping, you don't hear leaves rustling. You might hear like a soft thump on the ground, but that might be a lower pitch sound. So a lot of people get confused because, I hear some soft sounds. So why are you telling me I have a hearing loss? Because it's the shape of your hearing. It doesn't mean that all your hearing is down. It's that some of your hearing might be down first, and that might be contributing to you not hearing conversation. Difficulty understanding conversation in a large group or crowd. Again, it goes back to, the fact that speech has low pitch and high pitch sounds. And so you have low pitch and high pitch hearing, and you can lose a part of it and not all of it. So most people lose the high pitches first. And so it's exactly what it says on the slide. You hear the words, but you're mostly hearing vowels. You're not hearing the consonants. And that's because consonants take up a lot of the high pitch range of speech. So things like S's, TH's, F's, those are all high pitch sounds. Low pitch sounds are more like vowels, ah, oo, ee, ah. So you hear the words, but you don't quite know what was said, or you miss that last bit when people trail off at the end. So it's kind of like,
Dr. Lim.
Sure.
Sorry to interrupt you. I was wondering if you could tilt your computer a little bit forward.
Sure.
Your name currently is blocking your lips, and it's harder to read your lips for some of our participants.
Here we go. Is that better?
I think that's better. Thank you.
Perfect. Sorry about that. So, if you look at Wheel of Fortune, it's kind of like playing Wheel of Fortune. You have some of the sounds, but not all of the sounds. So you hear the vowels, and you got to buy the vowels. Consonants, you got to buy consonants. It's kind of the opposite. But it is really hard to pull out distinct speech clarity when you don't have access to hearing all of them.
So that's a perfect segue into talking about what the brain does with acoustic information and how it deals with hearing loss. So the picture that you see here is a representation of the sentence, Kate moves 2 red belts. And on the left-hand side, you'll see a nice colorful rainbow of a picture. You'll see that there's a lot more bright yellows in the low frequencies. This image is called a spectrogram, and what it's showing us is the sentence on the bottom. The sounds that are created when we say Kate moves 2 red belts are represented in time across the bottom. Across the y-axis here, this is frequencies from low frequencies up to high frequencies. So what Dr. Lim was just talking about, where there is so much energy where we use our voice, so vowels and sounds like M, there's a lot of strong energy. It gets very bright. And it also, you can see it's very low in frequency. Sounds like an S at the end of belts. You can see that there's some high frequency information way up at the top, but it's generally a much softer sound. So this is just another way to represent the sounds that we hear. Consonants, especially those where we're just pushing air through our teeth and we don't have that power of our voice. What I want you to look at on the right-hand side here, this is a representation of a high frequency hearing loss that starts at about 500 hertz, where the vowels are just kind of their strongest, and we see a sharp decline into the high frequencies, very much like what Dr. Lim was showing in both the anatomical representations and as she was talking about consonant versus vowels in a high frequency sensory neural hearing loss, which is the most common hearing loss with adults. So what you can see is there is definitely less information that is provided to the brain from the ear when we have damage to the ear. So you can think of the brain having to make do with an incomplete signal. Now, we use incomplete signals all the time. It's how we can do Wheel of Fortune. It's how we can listen in a noisy environment. Even with normal hearing, we're not getting all of the information. So the brain does a really good job of filling in what it misses. In fact, actually, if we took a representation of what the sound sounds like when you're listening through a cell phone, you're probably not going to get more than, can you see my cursor here? Right above the, where it says KHZ for kilohertz, on the left-hand side. Yeah, a little bit lower. Yeah, right about there is, that's about the highest information you'd get from your cell phone. So we are constantly understanding signals that are incomplete. And that's one of the beauties of the brain. Sometimes the brain's ability to make sense of what the information it has at hand can lead to some not so pleasant experiences. And I'm going to talk about that today. Okay, so this is a representation of the brain's tonotopic organization, that organization by frequency that Dr. Lim was talking about. This not only, it starts in the inner ear, but parts of the auditory system all the way up to the highest levels of the brain continue to be organized by frequency. And that is a beautiful structural aspect of the auditory system. But it also allows us to make lots of predictions. The brain can make lots of predictions about the sounds it hears because things are coded in a way that are predictable. One of the things that we've seen in many times in research models, and we're starting to be able to represent it in human imaging studies, is the consequences for that incomplete signal from the ear on higher levels of the auditory system. This is from one of those research models. This is not a human brain because we can't actually hear as high as some of these frequencies are. But it's a good representation for our current understanding for what happens when you have a significant hearing loss in some frequencies and not in others. So I want to walk you through this kind of rainbow picture. On the left-hand side, you're going to see those colors move from blue to red in kind of a very organized way. And there's plenty of space in the auditory brain for all of those different colors. All those colors represent the different frequencies that we hear around us, or in this case, a rat hears around them. So what we see with hearing loss is that's on the right-hand side. We see much more of the brain devoted to those lower frequencies and a slight disorganization of the frequency representation in the higher frequencies. This is probably not something that happens with a mild to moderate hearing loss in a human, but we do think that aspects of this happen with more significant hearing loss, and some of the experiences that people report with very significant hearing loss parallel what we might expect to happen based on these types of reorganizations. Now, this is a very simple model just based on frequency, but we know that the brain modifies itself based on the incoming information. And there's definitely a desire for the brain to make sense and interpret all of that information. That's what the brain on the right-hand side here is doing. It really wants to interpret all of the information that's coming in. And so what happens is different parts of the brain will start to pay more attention to frequencies that are more common. Because of the hearing loss, they don't have access to those, the higher frequencies. And so the brain really wants to interpret what's coming in. And so parts of the brain will kind of jump in and fill in when they're missing input. So one of the things that we understand about hearing loss due to the inner ear is that, as Dr. Lim said, the structural mechanisms of the inner ear make it very easy for a very well-tuned, very discrete piece of information for every sound that we make gets sent up to the brain. When that ear is damaged, not only do we not have some of the frequencies, but we know that tuning, as Dr. Lim mentioned, starts to get disrupted. I loved her analogies. They probably beat mine. Mine is always, because mine's old fashioned. I think of one of the tuning aspects as a radio, like an old fashioned radio. And if you snapped off the antenna, what you would get is it would be harder to find those radio stations. They would be softer, and there would be more distortion and a lot more overlap between those radios. You can kind of tune it in between those two stations and get both at the same time. And we kind of see in some of the studies that we're doing that happens in the brain. So that those hair cells are really, really important in creating a fine-tuned signal. When the signal gets less tuned, it can be harder to follow rapid changes in sound. And so that combined with brain changes as we age, and I'm not talking about, being 100, we see changes in the ability to follow rapid speech after about the age 22. So I think a vast majority of us are on that downhill slide for being able to interpret rapid changes in sound. So that happens. There's a combination of the ear and the brain that both make it more difficult to understand complicated, rapid input. Two other things. Dr. Lim already talked about noise, and it doesn't matter if it's a big restaurant or just one other person talking in the background. Both things are difficult, more difficult when you have hearing loss and are, again, over the age of 22. And then reverberation is another thing that we don't think about as much. So if you're thinking about your environment where you'd like to hear better, sometimes thinking about how reverberant it is can be helpful when you think about trying to hear better in an environment. So the other thing that I wanted to talk about today as a consequence of the dysfunction in the inner ear, in terms of the brain modifying what it does, is tinnitus. And tinnitus is, most people with tinnitus have some sort of hearing loss. And we understand there's a high correlation. It doesn't correlate with how much of a problem the tinnitus is for you, but it does correlate with whether or not you have hearing loss. The other thing is some people will say, well, I have normal hearing and I have tinnitus. And as Dr. Lim was mentioning, by the time you have a mild hearing loss, you definitely have structural changes in the inner ear. So while tinnitus is associated with kind of a mild or greater hearing loss, we do understand that you can have normal hearing and have tinnitus and have it be a result of changes in hearing over time. The other thing I wanted to mention was that tinnitus doesn't have to be ringing. People think of ringing in their ears. Tinnitus comes in all kinds of sounds, and they usually have the same cause, which is changes in the inner ear. There are other reasons that we have tinnitus, and some of them are consistent with different sounds. So a pulsing in your ear, sounding like it's coming from your ear, is less likely to be coming from a change in the inner ear directly. It's probably another cause, and so it's something to talk about with your doctor. And changes with different parts of the body. Sometimes people can say, well, when I clench my teeth or when my neck is sore, then I have different tinnitus. That happens as well. So if you have tinnitus and you're joining us today, you're not alone. About 1 in 5 Americans have tinnitus. It is a very active area of treatment research. It's the #1 reported disability in the military. And while that is not a optimistic statement, it does mean that there is a lot more active research going on than when I started thinking about tinnitus a couple decades ago. One of the things we always get asked in the clinic is there a cure for tinnitus? And right now, we don't have a way to prescribe something that will turn off your tinnitus. That said, it's not the same thing as saying that there's no treatment or there's nothing to be done. You just have to live with it. There is a lot that can be done. And there's a lot that's been shown to be helpful and help you have a better experience and better quality of life, even if the tinnitus doesn't completely go away. More hours of the day where you don't hear or notice the tinnitus. And the two areas that have been most successful in helping patients have a better experience with tinnitus is sound therapy and cognitive behavioral therapy with a component of stress management. For reasons that we won't get into today, the auditory system and other areas of the brain, like the limbic system and areas that really pay attention to sensory information, are more linked in some people than others and can become more linked over time. And so this second management technique can help disrupt those connections and make them more tenuous and allow for your brain less time with a very prominent tinnitus sound. So I want to talk about sound therapy first because we are audiologists and this is the component of treatment that we are able to provide. And an exceptional oversimplification, but a really good way to think about how sound therapy works is if you think about a candle in a dark room. Here's an image here of a candle in a dark room. It provides some light, but your eye goes directly to that candle because it is the most prominent sensory input in this image. If we raise the lighting a little bit, that candle is still prominent, but less so. What we're trying to do with sound therapy is provide more ambient and natural sounds, or sometimes we're going to purposely put sounds in around that tinnitus frequency and let it mix with the tinnitus sound so that it becomes part of an acoustic scene. Like you're seeing a scene here, it becomes part of that acoustic scene rather than the most prominent aspect of the scene. Yeah, and if we turn the lights all the way up where there's a lot of sounds, that candle becomes actually really hard to see. In many cases with tinnitus, we can create a sound that completely masks the tinnitus for a period of time. And this is really helpful to help patients get control over their tinnitus and feel like they have a little bit of relief from their tinnitus. It turns out it's not as good in terms of sound therapy as the last picture we saw where the tinnitus mixes in with the whole auditory scene. Yeah, that's better for treatment. This is better for kind of immediate relief. Okay, so we use these types of analogies to think about the sounds that we use and how they can provide different solutions for different needs at different times. Okay, next slide, please. Okay, so using sound therapy, there's no single trick. And one thing that you should be thinking about if you're thinking about sound therapy is maybe talking to an audiologist about the kinds of things that might work for your lifestyle and for your tinnitus. The good thing is, while we don't recommend spending a lot of time researching tinnitus on the internet because you'll find all kinds of things that are not well researched, and it does end up allowing your brain to kind of focus on your tinnitus a little bit more. One exception is learning about sound therapies online because there are a lot of really great apps and resources online to create sounds that are really helpful. So many more opportunities than there were 5 years ago. But you can go real low tech and get something like a fan or a table fountain the important thing is that it's comfortable and easy for you to use. It creates a sound that can both mix with your tinnitus and maybe mask it at times when you need to. Lots of patients use a combination of these devices for different needs over time. And might use in a day, maybe 3 of these to help with their tinnitus. Hearing aids are an excellent way to manage sound therapy because we have so much flexibility with the kinds of sounds that we can send in. And they do a really wonderful job of just raising all of the ambient noise in the areas of a hearing loss if you have it. That's a really fantastic way. But again, there's lots of ways to manage sound therapy and tons of sounds. The most important thing is that they're comfortable sounds for you to listen to, and that you that it's audible and can modulate the intensity from kind of just barely at the level of your tinnitus to maybe completely masking it out.
All righty. So we're on to our last portion here, and we're just going to talk about the consequences of untreated hearing loss and what we can do about it. So for consequences of untreated hearing loss, a lot of people think about hearing aids like they do reading glasses. Well, especially in COVID, they're like, I'm home alone, not talking to anyone, not going out, I'm not in a restaurant. Why should I do anything about my hearing loss? It doesn't bother me. And the thing to remember with hearing loss is that very few people have a sudden loss, meaning I wake up one day and I can't hear. Usually hearing loss occurs really gradually over time. So the average person, it takes a few years before you even notice that you have some difficulty. So if you think about where I'm sitting right now, if I didn't have any windows and my light bulb started to dim really slowly over time, it would take me a few years to be like, oh, it's kind of dim in here. I can still function, not a problem, but it does create more eye strain. Versus, if I turn off the lights, it's very sudden. It's very easy for you and me to tell that I'm suddenly in darkness. But if you think about a light bulb that dims really slowly over many years, you can function for a very long time with dim lighting. And there's always the patient who insists that they prefer dim lighting. Silence is golden, so why do anything about it? So one of the things we have looked into in the research for audiology is what happens when you don't use it. So similar to many other parts of the body, if you don't use it, you lose it. So there have been studies in the past where when you have untreated hearing loss, your ear gets a little lazy. It doesn't transcribe sound as clearly as it should. That's reversible. And when it showed that hearing loss was treated, the ear started working again and got less lazy. However, it does affect many other aspects of your life. You can get irritable, negative, angry. I'm so tired of asking people to repeat themselves that I'm just going to tune out. And that, leads to fatigue, tension, stress. At the end of the day, you're just so tired from having to strain to listen that some people end up withdrawing. Like, why bother? I'm not going to go to dinner with 3 people. I can't hear them anyway. So I'm much happier by myself at home. But that, affects your social isolation, which affects many other qualities of life, much like COVID did, I suppose. Avoidance or withdrawal from social situations, reduced alertness. If you can't hear things, you don't know they're happening. For example, one common thing people come in when they first get their new hearing aids, they say, I hear something following me. And then they realize it's their footsteps. But it's such a small thing. You don't think about it. For me, I don't think about my footsteps. Neither does anyone until you don't have it for many years and you suddenly get it back and you're like, what is that? Or things dropping. I was doing laundry the other day and something dropped. I forgot what it was, but it was like a tiny dink. And I thought to myself, if I had hearing loss and I didn't hear that, that probably would have been lost for, at least a few months until I went and cleaned out that closet. But it's these things that you reduce your awareness of your surroundings. And it can affect memory and just overall health. there's also a big study by out of Johns Hopkins from Frank Lin. He's an ear, nose, and throat physician, and he's looking at the effects of untreated hearing loss on overall cognition. And what the results are suggesting is that people with untreated hearing loss do have a faster rate of cognitive decline than people with treated hearing loss. So what that means is if you have hearing loss and you don't treat it, the study has shown that people with untreated hearing loss do have faster rates of cognitive decline than people with either normal hearing or treated hearing loss, meaning use of hearing aids. And many of the effects of not using hearing aids can be reversed with treatment. So, it's not to say that, oh, well, I haven't gotten mine in 3 years. What do I do now? It's not too late to start. So what we do find is that the longer you wait before you get hearing aids, the harder it is to adapt. It takes longer to adapt, but there is definitely an adaptation period. So again, think about if I sat in a dim room for really long, or if you all watch a movie and, at the end, the lights turn off and then the credits roll. And then if you stay long enough, the lights turn back on. You're like, ooh, that's too bright. Your eyes adjust really quickly. The ears take much longer. So when we give you new hearing aids, the research shows that it takes on average about 2 to 4 weeks for your brain to fully adapt to the new sounds. So what that means is that when, a lot like my glasses analogy, you get your new glasses, you put it on, bam, you're done. Everything's clear. You might have to go back to adjust the nose pads or, have the ear portions curved a little more, but you're done. You don't have to adapt. With hearing aids, because, you've gone so many years without hearing a lot of these sounds and you're suddenly getting all of them back, you might hear friends or family members that have said, well, hearing aids make everything really noisy. Not true. Life is noisy. Hearing aid returns your access to all that noise. So again, a common thing I hear back, the second week when people come back with their hearing aids is, well, silence is golden. Yes, we know that. But the more you wear them, we wear them full time, the faster you adapt. So, I've been told I'm a loud typer. So that's like the first thing I always show my patients is my typing, like you can hear that, or even your jacket rustling. I tell them when your jacket rustles, I can hear that, but I don't focus on it, just like that candle analogy, because my acoustic environment is very bright. I have access to everything in the room. But when you first get hearing aids, because you haven't had access to a lot of these soft environmental sounds, your brain is doing what it should. It should alert you to it. And so the first few weeks are definitely, there's some level of annoyance, but what we do is we tend to fit you to your prescription, and then we do a dimmer switch. Instead of turning all the lights on, we tone it down so that it's tolerable enough for you to wear it full time. And then as you wear them, we slowly ramp it back up. So again, you'll notice I use the word tolerable because I can make a hearing aid very comfortable initially. That just means it's not doing anything for you, because what's comfortable is the hearing loss that you're used to. And so there's a period of grit tolerance that you have to get through in order to get used to the new sounds again. So our take-home message here is that, there are many types of hearing losses. And just because you have the same results on a hearing test as, 2 other friends, by no means means that you will have the same experience with hearing or with the type of treatment for your hearing. Untreated hearing loss can cause a lot more problems than just not hearing, friends and family. And people who have their hearing treated do enjoy better quality of life. Treatment for tinnitus, if you have a hearing loss, the first step is definitely hearing aids, because that might do it for you. And there are obviously many more treatment options for tinnitus than just hearing aids if needed, but usually hearing aids are the first step. So how do I correct my hearing loss? So, there are many different types of technology. Just as you've seen phones and computers change over time, hearing aids are essentially little laptops on your ears. They are very high tech, and they do a lot more than just make sounds louder. So that's what they used to do. if there's actually a hearing aid museum I went to, and it actually had a throne, like a throne seat for a monarch, and it had like these acoustic horns built into the throne, so just like that, but it was subtle so that, you know, it's part of the throne, you can't tell I can't hear you. So it did start with acoustic horns way back when, but we've come a long way. So even this is definitely an old picture. These still exist. If you have enough hearing loss, you might need something this size and shape in order to help you. But for the majority of people, you know, you can use a wide range of styles of hearing devices. Now, a lot of people ask, well, which style is best for me? That depends on your hearing loss. So for some people, certain types of hearing aids will be better than others. For other people, you can choose any of these and they'll do equally well, but it really depends on you, your hearing. Another thing we take into account is your dexterity, because if you can't put it in, you're not going to be able to wear it. There are many other types of new styles. This is a picture of a lyric device. This is called an extended wear device, meaning it's like a contact lens. So an audiologist would put it in for you. It should stay in your ear for about 1.5 to 3 months. And, you know, eventually it clogs up with earwax and the battery will diminish over time. And then you come back into the office, we take it out and put a new one in. So this is a subscription type model. So you wear it 24/7. You don't touch it yourself. It stays in there and just does its own thing. So that's called the lyric device. Another most common type of hearing aid these days are what we call receiver in the ear or canal. They're called RICs. So if you look at this picture here, you see this little thin wire. It's pretty hard to see, but that's why they make it hard to see, so that cosmetically it's very appealing. If you compare that to any of these, it's very hard to see this one. It also sits, you can kind of see it peeking out here, but it sits right behind this little earlobe, and it sits right on your hairline. So it is very hard to see. So my hair, obviously you wouldn't see it. For people with less hair, you can, you know, get a skin tone color, or a lot of, I have a few people with no hair that match their glass frames because it sits right where your glasses sit. And so even with no hair, sometimes you just can't see it because it sits where your glasses sit. And this type of hearing aid is very good for the most common type of hearing loss, where you have better hearing in the low frequencies and more hearing loss in the higher frequencies. So why that helps is because if you look at this guy's ear canal, it's still very open. You can see a tiny little gray thing, which is the speaker where the sound comes out of. But it's leaving the ear pretty open. So the sounds that you hear normally and the bass tones would enter the ear naturally. And that speaker just gives you a boost in the higher pitches. And so I'd say about 85% of people are using this style of hearing aid. So like I said, you know, which type will work best for me really depends on your hearing. So, you know, I can't answer that unless I see your hearing results. We would need to see that. And we also discuss with you your dexterity, your needs. One of the biggest things that has changed this year is rechargeability. It's not this year. Rechargeability has been out for a while, but rechargeability that is pretty stable and reliable has come out in the last 3 to 4 years. So many more people are shifting to rechargeable. And then, of course, California got all our power outages. So then everyone's like, maybe I should go with a disposable battery. But that's a different issue. So a lot of these hearing aids are rechargeable, where you don't have to fuss with the little battery anymore. You can put it in a charger. They also are Bluetooth compatible. And I'm going to put a little asterisk there. Bluetooth compatible, generally speaking, yes. You know, there are a few things that don't work with it, but you know what that means is you can connect your hearing aids to your cell phone. You can answer phone calls, and you get it in both ears. So your hearing aids are now like little earphones. You can use your cell phone to control the volume. You can mute them. You can listen to YouTube or podcasts through your phone. They're your new headphones. So they do a lot these days. And then hearing noise, you know, this is kind of the holy grail of hearing aids, hearing and background noise. There's a lot of technology for that. You know, hearing aids have little microphones on them. They actually have 2 per ear. And the hearing aids are wireless, so they talk to each other. So they're kind of like buddies. And when you're in background noise, they try to focus on the loudest speaker. And some hearing aids, you can even have it set to, it only picks up in the direction you're looking. So if you're in a restaurant and you're facing, your friend or your spouse, then you're only picking up what you're looking at, and the things to the side are not as, they're just not picked up as much. If you turn your head, you can hear that. There's also feedback cancellation. So feedback that you've heard in the past of people having squealing in their ears, that really shouldn't be a problem. I mean, it does happen if you have earwax, if you cup your ear, it's expected, but the technology has improved significantly. And noise reduction, the hearing aids are always trying to reduce background noise. So yes, there's still going to be an adaptation period. No, you're not going to have noise cancellation, just like your Bose headphones. But the reason is because when you use headphones for music or your computer, you're plugging it into a source. So the earphones know exactly what you want to hear. With hearing aids, they're smart, but they're not that smart. They can't tell which human you want to talk to. So, if you have like a fan noise going or a fridge noise going, the hearing aid's really smart at turning, coffee grinders, machine noise off. But the problem is when the noise is other people talking. Hearing aids, we're still developing on that. But a lot of the newest hearing aids do have, artificial intelligence learning, where they are trying to learn what people prefer. So they're working on that, but it's never as smart as you are. So lots of changes in technology. There's also different levels of technology available in hearing aids. So for example, you might have a pair of hearing aids that go for $3,000 versus $7,000. The difference is not how they look physically, it's the chip on the inside and how advanced the technology is in picking up sounds and filtering out sounds. And again, what you should choose depends on your level of expectation. And that's something we discuss after we do your full evaluation to see what would suit you. Another thing that I always like to bring up is hearing aids alone are not always enough. Oftentimes they're not. They're a tool that we can use to improve your communication. But a lot of our job as audiologists is counseling, giving you information and training on how to best listen and communicate. We give you listening strategies. We discuss what you can do. And there are training programs, what I like to call physical therapy for your brain. Dr. Henderson Sabes actually developed the LACE program. And so I'll let her talk a little bit about that.
So while I developed one of these, there are now many ways that you can do auditory training for your ears. So you should talk to your audiologist about what they like to work with, because there are lots of options these days. But essentially, my perspective on this is that anything we can do to help your brain in that 4 weeks that Dr. Lim was talking about that make it so difficult to get used to the new sounds, anything we can do to help facilitate that would be really great. So the LACE program is one of those. It gives really challenging listening environments that you can do at home when you're relaxed with your hearing aids. And it also gives you some helpful hints about how to use your hearing aids. So it's kind of like having a little computerized audiologist help you with your hearing aids through that first month. And you can do it at home, which is now very convenient because you don't want to be going into the clinic a lot during these days, but it is an option to do that home-based adaptation and getting used to your hearing aids.
Very cool, thank you. And that's pretty much all we had to share with you today. There's lots more, obviously, but we wanted to keep it in a nice little package for you. So we'll open it up for questions.
So the first question, what generally accounts for variability in perceived volume of tinnitus from time to time?
I'll take a stab at that. I think by variation in loudness from time to time, I think I'm hearing that as, sometimes you wake up in the morning and your tinnitus is barely there, and other times it's quite loud. So we know there are some things that are associated with tinnitus perception. If you have tinnitus, stress, anxiety, and decreased sleep are kind of the big three. There are, other things like caffeine, salt. I'm not, those vary so much from person to person. You probably over time will kind of start learning. That said, we can't predict every time tinnitus is loud. Sometimes it's just something inside the auditory system or the other parts of the brain that are involved in tinnitus, and we have such a basic understanding of what's happening with tinnitus that we can't always predict that. But there are some things that we know are associated. Sleep and stress are two big ones.
All right, next question. How to better understand telephone conversations?
One of them is a lot of people use headsets these days. So especially if you're talking about customer service, one thing you can try is ask them to move the mic closer to their mouths. California also has what we call a California Telephone Access Program, CTAP. And if you have a hearing evaluation or a documented hearing loss, your physician or audiologist can sign the form for you to receive an amplified telephone at no charge. No further charges on your telephone bill. So yeah, if you come into our office and have a part of this, if you want to come in for an evaluation, we can do that for you, and then we can just sign a form saying that you're eligible to receive an amplified telephone. There are also caption telephones, and these are both state and federal programs. Caption telephones, I don't necessarily recommend for milder to moderate hearing losses. It's really when you're having really serious trouble. The reason is because the captions are really slow and they're not 100% accurate. But, for people with very severe hearing that really cannot distinguish speech over the phone, the caption phones can do really well. Another option is speakerphone. Not always the best in terms of privacy, but then you're hearing it with 2 ears. And of course, if you have a hearing loss, hearing aids are really going to help with that as well. Anything else you'd like to add, Dr. Henderson Sabes?
No, I think that's great. I think you touched on the fact that anytime you can hear a difficult conversation through both ears, for the vast majority of us, it's going to be easier. So anything that you can route that phone call to both ears, whether it's hearing aid or headset. And again, some of these headsets are really well amplified and can help you. And then I don't know your experience with apps, Dr. Lim, but there are some apps that are out there that will help you, especially with Zoom or anything through your laptop. But also
I see on chat someone put Sonic Cloud. That's a great one. Sonic Cloud is really great. So you can check that. I think someone put the link in there. So yes, Sonic Cloud is really great. So check out that link. It's in the chat.
We're fans.
Perfect. I love the sharing of resources. We are at Community Health Resource Center here. Next question, more about how to handle tinnitus. And someone did also add to the conversation, staying busy and distracted. But what are your thoughts?
So I think that's really great. I think if we were to kind of summarize the things that have been shown to help, it is finding lots of different sounds that you can use to help your auditory system, and then also find lots of things that can help the non-auditory parts of your brain that are involved in tinnitus. So reducing stress, staying active. So we call it pleasant activities. Have a list at the beginning of the day of like pleasant activities that you can do that you would enjoy when your tinnitus is kind of getting the best of you. And so having all of those resources together will be one of the things that can help over time.
Let's see. The next question is, do you help with hearing aids?
So yes, we do work with hearing aids. We do the full battery of audiology at University of the Pacific. So pediatrics through like babies through any age really. We do hearing aids, we do vestibular evaluations, we do tinnitus, we do counseling, pretty much anything you name in audiology we do. In terms of custom ear protectors in the ear, we don't typically recommend sound avoidance to treat tinnitus because it can make it worse. Do you want to add to that at all?
Yeah, I mean, you can use that candle analogy. And if you completely turn the lights off, then all you have is your tinnitus. For some people, more than a mild amount of noise can actually make the tinnitus greater. Sometimes sound therapy can help with that over time, and sometimes it's just that's how the tinnitus is. And so we have to kind of evaluate sound therapy and then see where we are. But generally speaking, using hearing protection in non-dangerous environments, it will make tinnitus more of a problem rather than less, and it can predispose you to other sensitivities to sound. So we don't recommend that unless you're routinely in a dangerous environment in terms of noise exposure.
Right. So in terms of noise exposure, we're talking like live sporting events. If you're there long enough and it's loud enough, firearm use, concerts, then yes, then we would recommend hearing protection. But if you're talking about everyday situations, I would not recommend using hearing protection for that. There are custom and non-custom hearing protection devices that you can use to listen safely to sounds that are very loud. So they do have what they call musician earplugs. So instead of just blocking everything, it filters a sound so that it's at a safe level when you're in these loud, dangerous situations, but not for everyday use. Again, what I would recommend is if you have tinnitus and you've never had a hearing test, the first thing you want to do is get a hearing test, because no one likes this answer, but if you have hearing loss, step one treatment for tinnitus is hearing aids. And that will solve a lot of the problems and more. And some people say, well, I'm sensitive to loud sounds. Why would I want to make sounds louder? Hearing aids actually help with that as well, if you're talking about hearing loss. So step one, hearing test would be the first thing in terms of tinnitus treatment. Sorry, go ahead.
No, I was going to read the next question. Are there specific inner ear hearing aids that are best for people with tinnitus?
So to clarify, it's not inner ear, because an inner ear would be an implant. So yes, sorry, go ahead.
Oh yeah, so a true inner ear aid would be a cochlear implant, which we didn't talk about today. But hearing aids can work for hearing loss, whether it's due to a middle ear or inner ear. But most of hearing loss in the adult population is inner ear related. Even the most straightforward hearing aid will usually help with tinnitus. The higher end hearing aids have a lot more options and flexibility for you in terms of those, all those different types of sounds we talked about. So that's where you can kind of see and make a decision with your audiologist about whether those things are worth having at your fingertips on an app or through the device. But even a basic hearing aid that just does very straightforward processing can be helpful for tinnitus.
There's a question on here that asks about finding a therapist or social worker to help with adjustments to life as hearing declines.
One therapist that we work with is Jennifer Gans, and she focuses in tinnitus. But yeah, I think most social workers and therapists do work with just life changes in general, of which hearing loss is one of them. But we'll include the information for Jennifer Gans to you.
I second. She's been a part of the cochlear implant group for a very long time. So she comes with lots of experience with tinnitus and hearing loss. And then I think what's been shown is, having a good counselor that you have a good relationship with. Certain aspects have been more documented in terms of evidence, like cognitive behavioral therapy. But as Dr. Lim said, many therapists can help walk through life changes, and it's very important that you have a good relationship with them.
Thank you. We have a lot of questions left. So does the tinnitus pill advertised on Facebook work? Someone answered, it's a scam.
Sorry.
No data. No data. Sorry.
Yeah. There's nothing approved by the FDA. If there was, we would certainly be calling all of our tinnitus patients. We're anxious to have something like that.
It'll be on Oprah. You get a pill. You get a pill. Everybody gets a pill.
Well, yeah, for sure.
Next question: can the high-pitched ringing ever go away?
Sometimes high-pitched ringing does go away. Sometimes it goes from constant to intermittent, and sometimes it's only there when sounds are very quiet. So I've had tinnitus for a long time. As over the years, it has changed. For me, if I'm wearing headsets for a long time or at night is when I notice it now. So I've had a trajectory that's very, very common for many of my patients. So it does change. In terms of going away, it does for some people, and it doesn't and for others. And we can't predict for whom it will change that way.
Thanks. Next, is there a connection with vertigo and tinnitus, as I had vertigo first, then tinnitus came, then hearing loss noted at age 36?
There can be. There are certain ear disorders that both will present vertigo and hearing and tinnitus and hearing loss. So yes, there can be.
All right. Next, I hear Costco has a great audio department. What are your thoughts?
Costco has hearing aids, and they have a great price. The main thing I would say, the difference between Costco and an audiologist is the level of training. So for an audiologist to be licensed, you need a doctoral degree, post-grad. And you're trained in the full range of diagnostics and treatment of hearing and balance disorders. Costco, I believe, they have their own training program for who they employ to become dispensers. Dispensers, I know that you need a high school diploma, and then it's kind of like an apprenticeship. I believe Costco has their like a month-long training program to teach them how to work with the devices. So I think, for some people, if you have a very what I call vanilla hearing loss, you might be just fine at Costco. If you have more involved issues and you need more expertise, then you'd probably have to go to someone with more training. So Costco sells good devices. They have an unbeatable price. In fact, it's cheaper for me to buy a hearing aid from Costco to sell to you than it would be for me to buy it from the manufacturer. Like, that's how low cost it is. But again, the difference in what you're paying for is the expertise and training.
Thank you. We still have a lot of questions to go through, so I'll just try to be fast. Next is, I did LACE years ago, but it was very discouraging. Every time I could succeed, it upped me right away to where I was failing again, basically almost punishing success rather than letting me integrate the skill. Mechanical voice saying good job didn't quite cut it for me. Anyway, I found it so frustrating and depressing to stay with it.
Different versions that are a little kinder.
Yes. So that it does happen, that patients can get frustrated. And one of the things that maybe wasn't explained was that we understand that to drive changes in the adult brain, it's often good to train at your threshold for understanding. And so that means that you get about 50% wrong. If that's unpleasant, it's probably not a great program for you to go through. So there are lots of other options that are that spend a lot more time at a skill level that you've kind of mastered. Hear Coach, and there's something by Medel, M-E-D-E-L, that are both great. The other thing that we didn't mention is something called Angel Sound, ANGELSOUND. It's completely self-driven. So you pick what you want to do, you decide what you want to listen and the kind of tasks that you do. So it's really super flexible. And then there's something called Clear, C-L-E-A-R, and I think it's clearforearworks.com. So there's lots out there. I definitely advocate working with your brain and sounds because we do think it does help for some people. So if you had an unpleasant experience, go ahead and try again and see if a different program works for you.
And yes, LACE is available even if you don't have hearing aids. You can do LACE with or without hearing aids.
Mm-hmm. Perfect. Next, to prevent hearing loss, are there any kind of foods, meds, or other therapy methods besides hearing protection to improve the health of the hair cells? When we are exposed to a sudden loud sound, there is a contraction in the middle ear, which creates sort of a temporary dampening sound of future sounds. Is there a way to replicate or reproduce this natural or biological response?
So in terms of foods, the military is working on this because obviously they have a lot of interest. And I think, like antioxidants are good for your whole body. Antioxidants, more antioxidants. But yeah, in terms of like actual diet, I think there's some data on this, but it's not so much clear as to like how much effect there is. But the military is working on it.
Yeah, the military is definitely working on a supplement. Right now, we would just say, from what we understand, a well-rounded diet would be the most, so nothing shattering there.
Yep. And then you do have a little reflex. It's called the acoustic reflex. It's a teeny weeny muscle attached to that teeny weeny bone so that when you hear a loud sound, it pulls on the bone to tighten that so it doesn't give you as much sound. It's a natural response. So some people have reported that they have discovered active control over that muscle. I am not one of those people. But no, there's not really a way to replicate it. Your body just does it naturally. But as you lose hearing, the level at which that threshold contracts is elevated. So no, unfortunately.
Thank you. This next question asks about free hearing tests at your office, some that were offered free last year, and if that's still valid now.
Yep. Your attendance to the lecture, you just tell, when you call our office, just tell them that you attended the Sutter lecture, and we will get you scheduled for an evaluation. Audiology is an essential service, so yes, we are open for in-person visits. We do have COVID screening questions, obviously, so you do have to pass the health screening to be able to get in the schedule and also get in the building. But yes, we are open.
This next person asks if, hearing aids just didn't work for him, and I think he wants to hear if there are alternatives for his tinnitus.
Short answer, yes.
Right. So, if we're talking just about tinnitus, then I would start with the two very evidence-based areas, which is other types of sound therapy. It doesn't have to come through a hearing aid. It's just more effective if you have hearing loss. But yeah, any kinds of sound therapies like we described or others. And then the other is, again, trying to kind of disrupt some of the connections between the auditory system and the other parts of the brain that are involved in tinnitus. And that's been one of the therapies that's been productive that we think is correlated with that is cognitive behavioral therapy and stress management. So those two would be where I would start.
The other thing too is there are many people who fit hearing aids. So if hearing aids didn't work for you, we would first have to know if they were fit well and fit properly and verified for your prescription, which involves real ear measurements. and compliance. Are you wearing them full time all day, every day? So all those factors also play into how effective a hearing aid will be for you.
Thanks. We may not get to all of the questions that are on here. I was wondering if I could get your help, perhaps typing some of these quicker responses, and if there are any that you think is really important to voice out loud, we could take the last 4 minutes to do that.
What sort of hearing damage creates sensation of pain with high decibel sounds? I mean, any type of high decibel sound at some point will hurt physically for everyone. So I don't quite know that question. If you have a more detailed version of that, please feel free to type that in. But for every creature with enough volume, it's going to hurt physically. Everyone is talking about the effects of treated versus untreated hearing loss. What about treated hearing? It's more advanced. I'm slightly confused by the question in terms of hearing partially successful treatment for hearing loss. So what we mean by successful treatment of hearing loss is that you're fit appropriately with a hearing aid and you're wearing it full time. That is successful treatment. Your success outcomes, if your goal was to hear really well in background noise, that's something we evaluate is if it's possible for you. For some people, that's no longer possible, even with successful treatment. And that's not something we can treat because we can't regrow your nerves. So successful treatment of hearing loss is to wear a well-fit hearing aid full time. That is the definition of a successful treatment. Successful outcome is a different issue. Someone asked about stem cell therapy. They are starting clinical trials, but right now the clinical trials are looking at regenerating the auditory nerve, not yet the stem cells. So there's still a few years to come there. It is not really bad to use one hearing aid. It's not optimal, but it's definitely better than using none. Again, it depends on your hearing loss. For some people, we might only recommend one, rare, but it depends on your hearing loss. The reason why we always say 2 ears is assuming the 2 ears are the same. If you only wear it on one ear, the other ear can get lazy. So that's why we recommend 2. Someone asked about referrals for pulsatile tinnitus. You would want pulsatile tinnitus meaning hearing the heartbeat. I would mention that to your primary care physician and any other types of symptoms you might be having. So one of the main things we are concerned about is there can be a tumor that grows on your auditory nerve. And one of the symptoms for that is a pulsing tinnitus. It's normal. Usually, it's very rare, but it's usually benign and slow growing, but it's still something we'd want to refer you for. Other symptoms would include vertigo, spinning, sensation of spinning, or oral fullness in one side of the ear. Anything else you want to add on that?
Yeah, I think because hearing your heartbeat is can be medically treated or be associated with something that we would want to medically treat, we ask that you talk to your doctor about that. And any ENT will be well versed in ear, nose, and throat doctor in the kinds of tests, and a primary care physician should be able to as well. So sound also travels through solid. How much hearing comes through our bones? Well, when we're talking face to face, most of what you're getting through your bones is your own voice. But we can actually use a hearing aid that uses bone conduction exclusively. And in fact, now there are headphones that you can wear that are waterproof and they're very sportive, that use bone conduction and keep your ear completely open. So it depends on if we have something vibrating the skull, we can be pretty effective at allowing you to hear through bone. But if you're just listening to someone across the table, very little is coming through bone conduction.
Do people with congenital hearing impairment also suffer cognitive impairment?
Not that I don't have any association. I know that children that have hearing impairment will sometimes have a more difficult time in school if they're not if there aren't accommodations for that. But in terms of a cognitive impairment, just due to, the inner ear, as we age, as you start to take that away, we can see it associated with a greater rate of cognitive decline. But in terms of congenital, I'm not aware of any association.
The other thing too, however, is that if you have congenital, which is stable through your lifespan, and then you start to lose more with age, that can. But purely congenital, I'm not aware of any information. Headsets are not generally dangerous for hearing and tinnitus, depending on how loud you're listening and how long you're listening. So if you listen to loud enough, long enough, anything can be dangerous for you. But if you're talking at a normal, reasonable volume, no.
Parkinson's and tinnitus or hearing loss. If you have Parkinson's, there is an association with a greater degree of hearing loss. It's not true for everyone. These are kind of bigger studies that I know of. I think it's associated with the dopamine changes, but it does increase your risk for both hearing loss and tinnitus.
And fast frequency sounds are called high pitched because they're high frequency. The low frequency sounds are kind of like this. Literally, the waves are much lower in the sinusoidal function, which is my assumption as to why it's called high and low pitched. Perfect. But pitch is the perceptual term for high and low frequencies.
Why do ears feel full, like they're waterlogged, if I'm drinking regular amounts of water from time to time? Sometimes ear fullness can be associated with dehydration, but more frequently it's related to other issues. So I would mention it to your physician. If it feels like it's full, we call that ear fullness or oral fullness, and it can be associated with things where the middle ear is not full at all. So it's good to have that conversation with your doctor.
So this person has tinnitus, and sometimes the tone suddenly changes from ringing to humming, and they'd like to know why.
We don't know. We don't really understand a lot of the underpinnings of tinnitus. There are some kind of vascular changes that can be associated with different pitch changes in the tinnitus. There are somatic, so different parts of our body, if we move them, we can sometimes change the tone or the characteristics of the tinnitus, clenching your teeth, moving your neck, those types of things. Those are all things we understand a little bit better, but most of the time we don't have a good idea. Oh, and hearing loss, changes in hearing can also be associated with changes in tinnitus. But most of the time we don't understand why. Sometimes it goes from the ringing to the hiss and then back to the ringing.
Mm-hmm. And because I clicked, I'll answer this live. No, I did not say that sounds are called high and low because they're high and low. I said that high frequency sounds are high pitched and low frequency sounds are low pitched.
Thank you so much for going over and answering all of the questions. This has been the most questions we've received in all of our time doing virtual presentations at Community Health Resource Center. Definitely love the engagement and all of your thoughtful responses, Dr. Henderson Sabes and Dr. Lim.